I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking to Chris Beyrer, director of the Johns Hopkins Center for Public Health and Human Rights and the Johns Hopkins Fogarty AIDS International Training and Research Program. Dr. Beyrer co-authored a recent Perspective article on the beginning of the end of AIDS. Dr. Beyrer, in your article, you describe a number of scientific advances against HIV in recent years. Which of these do you think is the most significant or the most promising?
Well, I have to say, I think there's a general consensus that one of the most powerful new findings, and indeed one of the ones which has led to this thinking that we might be able to control epidemic transmission of HIV at population levels, is the understanding that early and successful antiretroviral therapy is a potent preventive intervention as well as a key treatment intervention. And those findings really come out of the study known as HPTN 052, the HIV Prevention Trial Network study of discordant couples where one or the man or woman, these are all heterosexual couples, is living with HIV, and basically early treatment was provided to the infected partner, and it showed 96% efficacy in reducing transmission to the uninfected partner. And that has really opened up a whole new approach to thinking about epidemic control.
The title of your Perspective article, The Beginning of the End of AIDS, sounds very optimistic, but despite advances in science, you also highlight several obstacles that prevent us from achieving complete control of the epidemic. Some of those are social, stigma and discrimination, for example. There are also other barriers such as non-adherence to antiretroviral regimens. In your view, are those obstacles things we should be attacking country by country, or is there some of the solutions that are generalizable?
Well, it's a great question. I think, first of all, in terms of stigma and discrimination, certainly one thing we've seen is that treatment and the availability of widespread HIV testing and treatment services have had an enormous impact on reducing fear and stigma. After all, before antiviral therapy became available, of course, this was a uniformly fatal infection and a very difficult death, and people were right to be afraid of it, although, of course, that led to much stigma and discrimination against people living with the virus. Treatment really has changed that dynamic in many countries. However, of course, there are subpopulations, and in some settings, the majority of infections, for example, Eastern Europe and Central Asia, are among people who use drugs, injection drug users, and those populations still face enormous stigma and discrimination, legal barriers to treatment and care. And indeed, that is one part of the global epidemic which continues to expand in 2012. So we really do face some important challenges, and some of those are quite country-specific. A good example is that substitution therapy, which has been shown to have a very important impact on reducing HIV acquisition risk in opiate users, is still illegal in Russia. There's no methadone, no buprenorphine, and this has been an enormous barrier to that country's getting control of its HIV epidemic. I think the other issue that you raised, the question about adherence, in particular, is a problem with some of the new antiviral-based prevention approaches. So, for example, pre-exposure prophylaxis with Truvada, which was shown to be effective in reducing HIV acquisition in men who have sex with men. It turns out that adherence is critical. The same was found to be true in the successful trials we've now had of vaginal microbicides, topical pre-exposure prophylaxis approaches that women could use to reduce acquisition risk from men. There again, adherence turns out to be the Achilles heel of these approaches. There are just a wide array of new studies, mostly in the implementation science arena, trying to improve adherence to the use of these agents. Some are cell phone-based, some are peer and buddy-based, couples-based, and we're optimistic that we can do better. But of course, this leads us to looking still at other technologies, most importantly HIV vaccines, that would not be anywhere near as adherence dependent, and that probably are going to be critical to not just control epidemic spread, but really reduce new infections dramatically.
Another big obstacle, of course, is financial. The resources just don't meet the needs. Why has funding decreased, and what do you think it'll take to bring it back up again?
Yeah, well, this obviously is a critical piece of the puzzle. We are at something like a little under half of people globally who need to be on antiviral therapy getting it right now. And if we're going to realize the promises of treatment as prevention and of these new technologies to turn the epidemic around, we have to get way above 50%. In the U.S., as an example, the estimate is that only about 28% of Americans living with HIV are successfully virally suppressed and therefore, have greatly reduced infectiousness. That is a resource gap, and it is substantial. I think most analysts would argue that the decline in funding for AIDS has largely been driven by the global financial crisis and the reductions on the part of a number of particularly European donors. But there are some really heartening trends. The first, which came out at the conference, is that 2011 appears to be the first year where in-country resources actually account for a greater share of AIDS funding than donor aid. So countries themselves, and there have been leaders like South Africa and Botswana, are really beginning to pick up more and more of this burden. That has to happen. There has to be a shared responsibility and accountability and shared investment going forward. A second trend I think is really important is that there are a number of regional leaders, often referred to as the BRICS, the Brazil, Russia, India, China, South Africa, who have not been major donors and players in their regions, but who are beginning to move in that direction. That is going to be critical to shore up the resource needs. The gap was estimated by UNAIDS this year at roughly $7 billion, which is, of course, a substantial amount of money, but given the potential now to turn the epidemic around, it looks highly cost-effective, and in some countries, even cost-saving, and that's been clearly demonstrated with South Africa and cost-effectiveness in India, again, a paper presented at the conference.
Hillary Clinton has articulated the goal of an AIDS-free generation, but others point out that even without AIDS, the world won't be free of HIV infection for a very long time. What do you think it would take in terms of policy, funding, science, social change to stop transmission of the virus?
Well, that is a great question. I think, in articulating the AIDS-free generation and setting a goal, Secretary Clinton and the Obama administration writ large really did us all a tremendous service. It is very important to have a goal and to articulate what that goal means. But indeed, in looking forward to the potential of an AIDS-free generation, we know that HIV is going to be with us for a long time. And as we get more and more people on treatment, of course, their life expectancy is now approaching normal life expectancy. We're going to have many, many millions of people living with HIV and treated worldwide for a very long time. So, we accept that. But in terms of actually beginning to turn HIV transmission itself around, I think there are some critical unresolved issues. First, we are going to need better use and deployment of the new ARV-based prevention technologies, and that would be specifically bacterial microbicides. There's a new a ring that could probably be inserted for up to a month that we think is going to have a big impact on dealing with the adherence concerns. We're going to need to get pre-exposure prophylaxis to men who have sex with men. Probably is going to be a critical part of this. In terms of dealing with the funding gap in that $7 billion, there are a number of initiatives underway, and I think one that looks very promising is the idea of a financial transaction tax that actually was put forward by François Hollande, the new president of France, in a video address at the conference. And there is some real enthusiasm there for essentially having the financial sector pay small transaction taxes that could cover the funding gap in HIV quite quickly. Scientifically, I think probably an HIV vaccine is an essential. Virtually all viral epidemics in humans that have been controlled, and the only one that's been eradicated, smallpox, have been done so with an effective vaccine. And of course, we now have at least one trial with a positive signal, RV144, the Walter Reed trial in Thai adults, that is at least pointing ways forward. Particularly in the area of antibody-based vaccine approaches or combination vaccine approaches. That does lead, for the first time anyway, to some people thinking that this, too, is going to be possible.
You mentioned the conference, the 19th International AIDS Conference that just ended in Washington. What would you say were the key take-home messages from that?
Well, I think certainly the world coming together and all the stakeholders and players in the AIDS response, governments, scientists, community, people living with HIV, the political leadership, coming together and really agreeing on this shared goal of an AIDS-free generation is really something of a turning point. I think that was critical. There is very much a consensus that the first thing that really can be achieved is likely to be dramatic reductions of virtual eradication of pediatric HIV transmission. And that is doable with the tools we have now. And I think there was very much a renewed commitment and a great deal of enthusiasm for this being possible. I think certainly a take-home message on the critical implementation of the tools we have now and figuring out their strategic use. So really a move toward implementation science as a next critical step. People have talked about efficiency and effectiveness, about combination preventive and treatment interventions. That was very much a message that came out that going forward we need to really use the tools of science to optimize what we have now and put the resources we have to the most effective use. I think that will be a defining outcome of the conference.
So did the conference change your view of the future, either for better or worse?
Well, it certainly set many of us up with a great deal more work to do. I think one of the outcomes, unfortunately, on a downside, was a recognition, really, of the gravity of some of the sub-epidemics underway and the huge challenges we face in getting control of those. And a good example is the epidemic among minority men who have sex with men in the United States, the epidemics among drug users in Eurasia. These are stubborn problems, and I think the conference underscored just how little progress we've made, how far we have to go, and what a difficult task those responses are going to be.
Thank you, Dr. Beyrer.
Thank you.